Stephen Hawking, Ralph Braun, John Hockenberry, Marley Matlin, Lennon Moreno, Franklin D. Roosevelt, and Stevie Wonder. What do all these people have in common? They are examples of many people who have achieved great success in their respective fields despite their significant disabilities. Could we say that their success has been complemented by early access to diagnosis and therapy? But despite centuries of such examples, people living with disabilities are still denied equal opportunities on a number of social and economic fronts, including investment into the development of their human capital. Why should you be concerned about the lack of early diagnosis and therapy? Because even you, like classical music composer Beethoven, Superman actor Christopher Reeves, can suffer calamity in your prime and become disabled. This evening, we look into what we can learn from the work being done globally to avail access to early diagnosis and therapy for children born with disabilities. We speak to clinical supervisor and visiting professor, Ohio University, Janice Wright, and speech-language pathologist and audiologist of Mariri Stimulation Center, Kutlelo Mariri. And the first question we ask our guest is to identify the key considerations an adult or guardian must have when raising a disabled child in molding them to become competent.
I think the key here is not to treat them any differently. That every child will learn and grow. Some learn and grow differently and at a slower pace than other children, but we are all different. And so even though a child has a disability doesn't mean that they shouldn't socialize from a very, very early age. In the United States, we have early intervention, and that means that from the very beginning, once a child has been identified as having a problem, we begin that process of socialization. We have expectations for our children that they will interact with family members, they will interact with others, they are a part of play groups, they go a variety of different places. Sometimes we have to adapt the environment to the child. I've been in Gaborone 3 years now, and one of the things that I've noticed is that sometimes it's difficult to get around because the streets are uneven, or so if you have a child in a wheelchair, it might be difficult to get them places, but it's really important to take them where other children are so that they can play.
And like Genesis said, just taken from the US perspective, and when you bring it back home, the therapies is actually a new field in Africa. So you can imagine in a country like ours, it's actually even newer. So when I started with Princess Marina Hospital, where I established the Department of Speech Therapy and Audiology. So I realized that as special needs kids, we intervene at a very late age, and that it was very important to do an early intervention program. Hence, that's why we are running an early intervention program, which actually looks at a child and try to integrate them in the world, making sure that they have equal opportunities, just like any other child growing. So it's still an ongoing process. And for our program, for example, it's very important that the kids go out on outings. So that, for example, if their relatives or their cousins are having parties at Wimpy, they're not left behind at home because the parents are thinking, oh, how am I going to manage my child? So that is very important.
What would you say are the key considerations an adult or a guardian must have in raising or molding a child with disabilities to become competent in the labor market?
In the United States, we have programs that follow the child from a very early age. Again, early intervention, I don't think we can say that enough. Early intervention is key. The sooner you can identify a child's needs, the sooner we can begin to transition them through that process. As with our typically developing children, as a parent, I know my child reached certain milestones and I had certain expectations. The same with children with disabilities. But if we don't intervene early enough, if we wait until they are 6 or 7, then those early years that you learn how to play with people, you learn how to communicate, you learn how to do turn taking, if we don't do that early enough, if the parents don't do that early enough, then you have a child that never learned. And so you're now trying to do 7 years of catch up. You know, you're now trying to train them 7 years into their life. So I think that one of the things that parents can do is to, if they have any suspicion that their child might need help, is to find that help. I know that one of the things that we've talked about is that's difficult here, which is part of the reason why we come from the United States to assist in helping to identify. But that's really I think that's the most important key there, is early identification.
And I think what is very important is firstly for the parent to educate themselves. If immediately, like Janice is saying, you're suspecting, go to the pediatricians, ask about therapies that are available in the country, go and have an assessment. If you are suspecting and you are worrying for nothing, the therapist will say, no, don't worry, let's just wait and see. But if there's a need, then they start therapy early. And when you start it earlier, then you are giving your child opportunity to come and be productive. So it is very, very important for parents to come as early as possible. And one of the things that I normally find in the clinic and in our program, I always ask parents, why did you wait until the child is 4 years old?
Yes.
To come for therapy? Because we have lost 4 years of learning language, which means we are behind, and we are going to be behind into the primary school. And again, remember now, there's peer pressure from the parents and the colleagues. They had about kids, and my friend had a child at 4 years. Next year they're going to reception. My child also has to go to reception. And what do? We push kids into reception. Whether they are ready or not, we don't really look into it. And eventually at standard 3, standard 4, now the child is not performing, because the more difficult it is, the more the child will get challenges, and then they will not proceed. But when I worked with the kids, I realized this child had potential. If we are more patient enough to support this child, they could have gone to the school and do well and be independent.
Right. And that's the same in the United States. Parents are reluctant to say, I think my child has a problem. And they might go to their friend who says, oh, they'll outgrow it. They're not talking at 2, they'll grow up and they'll talk. Well, if they're not talking by 2, there might be a problem. And it's really important to, again, go to the pediatrician, find out where services are available, and at least get that assessment done. And as was said, if there's not a problem, we'd be the first to say, no, there's not a problem. But if there is, then we've identified it very early on. I mentioned in the United States, we start at birth. And sometimes before birth, if a parent knows that they're going to have a child with some kind of genetic disability, we can start with that parent even before the baby is born to talk about how to engage that child. And our programs are really birth up until old age with anyone who has an identified disability.
This evening, we look into what we can learn from the work being done globally to avail access to early diagnosis and therapy for children born with disabilities. Janice Wright enlightens us on what is being done in the USA to create a conducive environment for children with disabilities to excel to their best potential.
I think one of the major things, again, is starting early. But one of the issues that I see here is that there are no services in the schools. And that the children who there's no support services, there's no speech therapy, there's no physical therapy, there's no physiotherapy, there's no occupational therapy. And although teachers have passion for working with these children, they don't have the support. In the United States, any child with an identified disability is eligible for services from any of those related fields. Every school has a speech pathologist, physical therapist, occupational therapist, audiologist. That works with that child.
From your perspective, why do you think that this is not a priority?
Like I said, this profession I knew in the world. But in Botswana, we really concentrate on the medical aspect. If somebody has got a stroke, for example, all we want to do is to preserve life, which is important. But the world is no longer doing that. They're saying, We have preserved life, but now we want this life to be productive. So we've been focusing more on medical, not rehabilitation, not improving the quality of life.
Last year we went out to the School for the Deaf, and I don't know the name of the village. I'm sorry, I don't remember that. But we were working with a young man there who they had identified as being deaf. He was not. He had not had the testing done. He was what we call an elective mute. So he chose not to talk. And he had been there since he was 6. He was now 13. So for 7 years, he was at the School for the Deaf. He was hearing, but he did not talk. In 15 minutes, we were able to get him to speak because he had the capacity. He had the voice, he had the vocal, he had the vocal capacity, but no one had assessed his skills. No one knew what he could do. They don't have the specialists out there, and the teachers didn't have the support in order to engage in some kind of therapy. So if as I was saying earlier, if I could do that in 15 minutes to get him to speak, to say his name, to tell how old he was, to tell us what village he was from, just think what could happen to many of those children if they had those support services that they worked along with the teacher. He was 13. I met another young man who was 15. He's getting ready to move out of the school system because 16 is where you move at this age. He was getting ready to move out. He lost his hearing at the age of 4, which meant he had language. But because he was at the School for the Deaf and they don't use oral language, they use sign, he also did not speak. Again, in 20 minutes, we had him using his voice. He's very bright, very intelligent young man. But in order to work in the world, he has to be able to do a number of things. And so I asked, the teacher, I said, well, if you want him to work, he needs to be able to use everything that he has, not just one thing. But part of the problem is they just didn't have the support in order to do that.
So we need, as Botswana, to say, people who get sick, like Jenny's was saying, as you get older, I've got patients who came and said, I want to resign my job because I can't hear. And I'm like, no, at 32, how many years do you still have to live? You want to resign because you can't hear in the meeting? We've got super nice hearing aids available that are very small. Of course, they're expensive, but then you can have access to them, you can wear them. But again, look at the stroke patients. Like she said, we don't have a rehab center. So even patients, sometimes I have met patients where I thought, wow, with intensive therapy, they could go back to work. Yeah. But because of lack of the services, eventually they go for medical boarding and say, you can't perform, you have to go back home. And imagine at 40, and you're going to live 30 years more. And even your family, you are the breadwinner. You are no longer working. What's going to happen to your family? And also because when now you have to take care of that patient continuously, it's heavy on the family, emotionally as well as financially.
Are you insinuating that this implies that the infrastructures that are in place for disabled people are not enough of a priority from child development stages up until when they're in the labor force?
I think we missed it out. We really missed it out. And I believe it's never too late, It's never too late. And I believe that we need to go back and do things right so that we can actually serve special needs people in this country.
Oh my gosh. I wouldn't do what I do unless I see gains. I've been a speech pathologist, for 30 some years. And I see some of my former clients, some of my former patients who I started working with them when they were 2. So they're now 32. And they will still come up to me and say, do you remember me? And because they were here and now they're way up here, I don't remember them, but they remember me. And they may not always use a voice, they might use a computer to talk, they might use pictures to talk, but they are communicating and they are productive members of society, many of them. They may not be a doctor, but they might be working in a doctor's office. They may not be a teacher, but they might be working with younger children in a preschool program. And these are children that when they were little, you would look at them and go, oh my gosh, I don't know what is going to happen. But there's so much success that happens when therapy is given, when it's started early, when it continues, when they're supported throughout their school program. Then I think that I wouldn't still be doing what I do if I didn't find progress in therapy.
I think for us also, the program is that when we have a new child who comes and not talking, and the parents in so much pain and tears, and then after the process, the child starts saying mama, and the light in that parents, it's just so fulfilling. We actually forget the hard work that we have put in. Mm-hmm. And to have them join the mainstream, like we have two who will be joining the next year, it says, yes, it was worth doing it.
Yes.
Give us an idea of the magnitude of the problem of children who have got no access to rehabilitation services or the like in Botswana.
You see, it's very difficult because in Botswana we really don't have true statistics that I can pinpoint. But let me just give you a scenario. When I was in government, like I said, when I was in Princess Marina, I started a department, we started doing public education, people started coming in. And in therapy, you need to come at least once a week or twice a week, so that it can be beneficial. So it came to a point where I will see somebody in January and follow up in 6 months' time, which it will be in June. And then when you look at it, can you really make a difference with that patient? No, there will be no difference because they're skipping. So every time they're coming, you are doing assessment because you want to see how far have they gone. Now being in the private sector, in 2 years back, we started only with 3 kids in our program who need speech therapy. We never actually even marketed it. We piloted it because I wanted to say, can this program really, really help the kids? Can it improve the quality of life? Now we're having about 31 kids in the program. And some of them will come from different places like Maung, Fraserstown. They had to be returned because the parents said we can't afford to pay this. So it's a big challenge.
What is your suggestion in creating access to rehabilitation services for those parents who are even in remote areas, who you say, like you said, from underprivileged communities that could have access to a place like Princess Marina, for instance, where they could get diagnosed on the condition of their children?
It's really going to be a challenge because the ministry should ensure that at least with the referral hospitals, we have more therapists, because if we can have more, not only 2 or 3, because that is too little for intensive therapy, that will make a difference. Because then you need to have others who can do outreach programs where there can be continuous follow-up. Unless we have that, it's just talk.
So what would you give as your final advice to decision makers and Botswana in general?
Like most of the time in this country, we keep on saying we're going to benchmark, we're going to benchmark. And I want to say, what, I always said to people, we have to be realistic. We have genius coming here to help us. We need to listen to these guys and try to benchmark from what they're saying and try to direct services so that each and every person can have access to this eventually, not tomorrow, because it's a process. Mm-hmm. And it has to be a realistic process. And we have to do it in phases. We cannot jump the ship. We have to do it in phases. And also countries like South Africa, just our neighbor, when you go there and see what they're doing, it's just amazing. We can just benchmark, come and bring it back home. Work hard to make sure that we give Botswana access to therapies.
In the United States, it was the parents. The parents went to the government officials and said, we must have these services for our children. Autism around the world has increased triple, quadruple, and parents said, we must have. They went to legislators, they went to government officials and said, our children need these services. And so it's really important for not just the professionals, but also the parents to say, this is what I am demanding from you because I want my child to be successful. I want my child to be an independent, functioning human being just like everybody else. And that I think that would be one of the things that I would say is parents go to the officials and say, this is what we want.
The other problem in Botswana is that we work as units. We need to collaborate. So that the Ministry of Health will say to Ministry of Education, you know, I've got 30 kids with hearing loss. And we need to place them eventually in 5 years' time to go to schools. Please get them ready. Please get facilities like FM systems in the classroom, get carpets in the classroom so that these kids can actually benefit. We need to collaborate.
What has been your experience in the Botswana context?
What we found is that because there's only one speech pathologist that can do the identification, it can take up to 3 years for a child to be assessed. And that the parents have to bring the child into Gaborone with the CRC. So that puts a burden on the family as well. So if you're taking a look at a parent who might identify difficulties with their child at 2, but it takes 3 years to do the assessment, that means they're now 5. And we've missed that window of opportunity. Children's brains are very elastic. They absorb, they can adapt and adjust. Even if you have a child, for example, who had trauma at birth, and so maybe one part of their brain is not functioning, because they're so young, the other parts of the brain can take over for that part that maybe wasn't working well at the very beginning. But by the time they're 5 and 6, that plasticity is no longer quite as malleable. And so although there are still benefits, I'm not saying that there's not, but the earlier you can identify, the earlier you can diagnose, the earlier we can provide supports for those families. That's what we found in the United States, is that we can't wait until they reach school age before we begin to do interventions. And then here, there are no support services in the schools. So even if you have a child that you want to go to a typical school, they do need support. They need rehab services even in the schools. And those don't exist here, at least from what I found.
From myself, Bonolo Molezane, the rest of the First Issues crew, our most valued sponsor, First National Bank, we wish you a pleasant viewing and a good evening.